Okay, well, welcome. This is the Ophthalmic Clinical Education Summit sponsored by Zeiss, and I want to welcome all of you. My name is Rick Lewis. I'm an ophthalmologist specializing in glaucoma. I'm based in Sacramento, California, and I've been practicing glaucoma for approximately 35 to 40 years. Raised and born on the Humphrey visual field machine and have used it ever since. And I think we're going to have a lot to say about some of the new features tonight. Now with me tonight, we have Shalini Saad, who's from the Cole Clinic in Cleveland. Welcome, and perhaps you could talk about your background in glaucoma.
Sure. So I trained in the University of Illinois in Chicago and did my fellowship at Emory. And now I'm at Cleveland Clinic Cole Eye for the last 9 years, been practicing for almost 13 years. So I really enjoy being a glaucoma specialist and also practicing comprehensive ophthalmology as well.
Great, welcome. And also joining us tonight is Michael Shalazian, and I hope I'm pronouncing your last name correctly. I apologize if I'm not. Perhaps you could tell us your background and your interest in glaucoma.
Sure, Rick, thank you. So following graduating from optometry school, I did my residency in ocular disease in Philadelphia, worked with a number of glaucoma specialists from Hahnemann University, and then joined the faculty here at the Illinois College of Optometry and practicing in the Illinois Eye Institute. And just have always had a passion for glaucoma care, treatment, and management, teaching students and residents, and currently I'm the president of the Optometric Glaucoma Society, and really pleased to be here with everyone this evening.
Well, thank you for coming. And again, you know, the foundation for visual fields and glaucoma goes back well over 100 years. The innovations, the progress that has been made, and a better understanding the visual field defects that occur is sort of a crucial part of everything we do. I think we've all been challenged this last 6 months by COVID, and how do we manage eye problems, particularly glaucoma problems. And we're going to talk tonight about some of the innovations, some of the challenges. We're going to talk about how we actually clean the visual field machine. This is a very good agenda. Perhaps the two panelists can tell me, how has COVID impacted your care of glaucoma over the past 6 months, and how are you currently managing it?
Yeah, so, I'm in Ohio, and basically March 17th is kind of when we shut down. Ohio was kind of a little fast to get shut down, which was good. And then we reopened in May. About 50% was kind of how we reopened. But during those couple months that we were shut down, we were just seeing urgent, emergent patients, and really we weren't doing any visual fields. But as you know, with our glaucoma patients, typically seeing them 3-4 times a year. So that time was really a challenge for those patients who had planned their visits 6 months ago. So we were converting to hybrid visits, sometimes just coming in for a quick pressure check, following with virtual, or trying to do virtual just to keep that connection, to review medications, refills. But then now we're back up to 90%, and which is great news, and back to surgeries, almost getting back to the normal volume, and doing visual fields. And really, actually, the fortuitous part of it is that I've converted to the HFA3 just in the last 2 months, and moved to CETA and the 24-2C. I've really found it to be a great tool, especially during this COVID time when we're trying to minimize chair time, exposure to patients, and then still get some good, valuable, reliable information.
That's great. And maybe we'll be able to come back to that after, as the folks who are attending this can see. This is the agenda tonight. We've got discussions by Michael and Shalini on visual field testing and imaging. We're going to have a panel discussion where we'll have a chance to really go into greater detail on that, as well as answer any questions. We're going to follow that with case presentations, an additional panel discussion, and then we're going to get a special talk on the future regarding perimetry from Gary Lee, who's one of the research directors at Zeiss. Michael, any thoughts about how you're managing COVID and glaucoma in these last 6 months?
I think Shalini said it very well. I think our emphasis has been on efficiency. And that's, we've always been focused on efficiency. Sometimes it's difficult in an academic teaching environment. but taking the opportunity for good imaging with, fundus imaging with the Zeiss Claris camera, faster visual field tests. And I know that in other presentations along in this series, they're focusing on the progression analysis that comes with the Zeiss Forum Viewer software. So those tools give me the advantage of seeing patients more efficiently, making the right decisions, and working with the 2 glaucoma surgeons that we have here, making the best decisions for our patients.
That's great. Yeah, these are very interesting times, and I know all of us can't wait for this pandemic to go on. But in the meanwhile, I think we're all going to be stuck with this for quite a while. This is not going to go away in the next few months, and perhaps could be with us for a year. So I think whatever insight we all can provide would be a benefit to the practitioners out there. So with that, why don't we start in on the actual presentations? And again, this is going to be focusing on visual field testing and imaging. And I look forward to hearing the talks.
Okay, so let's go ahead and get started here with our first section, which is on visual field testing and imaging. We are going to go through a number of case examples using our diagnostic devices in our glaucoma patients. One of the things, though, I think we wanted to start off in the quick discussion is to identify that this is a different era, and as everyone is saying today, it's a new normal. And we have slightly modified protocols that have been impacted by COVID and our patients with COVID. And we have to also adhere to our consensus guidelines for the practice and management of glaucoma patients. So with that theme in mind, one of the things that I've been striving to do over the past several months is to make sure that I am very efficient, very practical, and well documented in my diagnostic testing. So using fundus photography, using OCT, and using visual fields are still the basic guideline testing that I need to do on my glaucoma patients. And yet I want to review that and acquire that in as efficient as manner as possible. Shalini, how has COVID affected your practice and your patients? And do you agree that we need to be more efficient with our patients? And what are we moving towards in the future or currently?
Right. I agree with you, Michael. It's all about, efficiency, less chair time, getting our patients in and out of the office safely, but still getting the valuable information through our diagnostic testing and examinations. And I know you kind of mentioned that getting back to normal, but also heard this idea of maybe getting back to better during this COVID time. And
yeah.
So maybe, moving towards newer diagnostic testing faster, like the 24-2C CETA faster might be something better for us to offer to our patients. And so with the CETA faster, previously, I will say I was pretty much doing CETA standard on every patient unless they were unable to do CETA standard due to whatever limitations, then I would do CETA fast less frequently. But after we've kind of gone into this time, I've been doing the CETA faster and have been very impressed with the information that I'm getting back. The CETA faster is actually 30% faster than CETA fast testing. They've gotten basically rid of the false negative reliability. Blind spot monitoring has been replaced with gaze tracking. And all of these modifications have led to shorter time for my patients in the visual field testing. So I think this has been something I'm very excited about being able to have the opportunity to use.
Yeah, I have a quick case example here of a comparison from the same patient who took a traditional 24-2 CETA faster, the new faster algorithm, but then also did on the same test day the 24-2C program that adds in those extra 10 central points to help us highlight the highest risk, if you will, for central visual field defects in our glaucoma patients. And you can see there that the 24-2C test pattern did not add substantially to the test time. We're still just over 3 minutes per eye. and under 3 minutes for the CETA faster in the traditional format on the left side of the program there. So I think you're exactly right there, where initially when COVID hit, it was like, we're not doing visual field tests at all, and we're afraid of everything. Now we have protocols to disinfect the perimeter, disinfect the bowl. We can do it under, with appropriate safety precautions, and we still need to acquire all of this diagnostic testing for our patients.
Yeah, and I will mention also, there is always a fan running, within that
Yep.
bowl in the machine, and if you keep the door open and allow that ventilation, you can almost think of it as it's just as safe as them being in the clinic with you in the exam room, face to face with your mask on. I think there's definitely less exposure sitting in that ventilated visual field room, and especially such a short amount of time. So. Another reason to kind of switch to the CETA faster.
I think the one tip is to obviously watch out for fogging of the trial lens, and watching out
Sure.
for the position of the mask, and sometimes using a piece of surgical tape on the top side of the mask to decrease the fogging that can sometimes develop.
Completely agree. I'm pretty much having all patients doing that. But again, shorter testing time, less time of that fogging issues, and patients can do this reliably and get your information.
Yeah. Okay, so one of the other themes that I was focusing on in my first section here was fundus image acquisition. One of the camera systems that I've been using for the past 2 years now is the Claris system from Zeiss. And I really like the wide field and ultra wide field and montage capabilities of this. It affords me an easy way to get a great view of the back of the eye. In addition to my own clinical examination, this obviously is a good reference point. And while there's been so much attention and hype, if you will, not hype, that's not the right word, but focus on OCT testing over the past 10 years or so, people have forgotten about good fundus imaging. And when you have a great camera system and you can get a wide field 133-degree image like this in a stereo pair for a patient, and you can zoom in and get stereo disc analysis and do the things that we are supposed to be doing as ophthalmologists and optometrists and glaucoma specialists, and looking at the optic nerve and using our skill set there to identify change in the back of the eye. It's just really helpful, and also very helpful to be able to get an overview of all the other potential pathology in the retina out to the peripheral retina there. So that's very helpful and very efficient.
I think you make a good point, Michael. I think sometimes we it's easy to just naturally just go do an OCT on every patient and forget about the fundus photography. But it definitely adds value, and those patients that to really critically be able to look at that nerve. If you've got the old fundus photos and you can follow up with a new one and see if there's some potential subtle notching or peripapillary atrophy, sloping, then even sometimes, a disc hemorrhage that could be picked up that you maybe just didn't see as quickly as the patient blinks. So I think there's definitely value in doing those fundus photography as well.
Yep. Here's the same patient using the caliper measuring system that's included with the Claris, just in case you need to do that sort of thing. It's available to you. And while I don't typically do a lot of ultra wide field imaging on my glaucoma patients, that is one of the options and features of the Claris system. 200 degrees out in two fundus images here, and if you wanted to do a montage and go further and go more superior and inferior, you can do that as well. And the true color option that the Claris provides is a nice advantage over some of the other systems that are out there. Again, baseline photographs of a patient of mine who is ocular hypertensive. You can see the wide field photos there. The next slide shows right and left optic discs, a relatively small disc and small cupping. Those are sometimes the more difficult ones to judge with early glaucoma's change. There's, a little bit of maybe irregularity around the disc margin and maybe a little bit different in disc size. So while I'll often use my OCT to look at disc size, Again, with a good camera system like the Claris, you can actually measure that and see if there's a difference in asymmetry between the overall disc size that would account for a difference in the cup size and the neuroretinal rim area and things like that, and give you more information about your assessment of the overall health of the optic disc. And then this patient who was ocular hypertensive had been following for a while, and my slide here is just to reiterate that, you know, when everything is integrated together, and I think that's a real, you know, important aspect for eye care practitioners to think about the integration of their diagnostic devices so that they can assimilate all the data together, integrate all the data together from even different instruments and in different companies when necessary, so that you can get a good overview of the fundus photo, visual field, RNFL, and ganglion cell map area, so that you can identify where change might be developing in these ocular hypertensive patients. Next example is, again, a Claris photo, wide field and stereoscopic of a patient with very advanced glaucoma. You have the ability to zoom in and look very carefully at the optic disc and very thin neuroretinal rim. You know, of course, documenting end stage or advanced stage glaucoma is not always necessary, but having this in the patient's library of diagnostic imaging is often helpful down the road as our patients are living longer and longer, and you know, we need something to refer back to really identify if there's any change of the optic nerve or in the retina. Next example here is of a wide field photo of a patient with glaucoma and a disc hemorrhage. And it's just identifiable there at the 7, 8 o'clock position on the disc margin. And then I highlighted with annotations from the Claris camera where the disc hemorrhage is and what I identified as an area of retinal nerve fiber layer dropout that I seemed to identify based on the loss of the reflection of the retinal nerve fiber layer there. And putting everything together, structure function analysis in the forum viewer layout allows me to identify these high-risk patients with split fixation visual field. Is it progressing? We'll use our progression analysis, of course, and set lower target pressures as I identify these patients with very severe disease. Some individuals may like a different report that you get out of the forum viewer software, and that's called the combined report. It depends on what type of layout you like and how the practitioner likes to review the data. You're able to put right eye and left eye together and put the fundus image, OCT, and visual field. So using all of this data together really helps us make our decisions more easily and more efficiently. This 60-year-old patient with ocular hypertension knew he had ocular hypertension for a number of years, skipped appointments over a couple of years, unfortunately, and then was at home one evening doing crossword puzzles and happened to cover his left eye. If you look carefully there on the photograph, you can perhaps identify a superior temporal region of nerve fiber layer loss. And he happened to identify a scotoma on the crossword puzzle in his right eye, some distortion that he noted just by happenstance. He came back in. We took the photograph that I just showed you. We did a PanoMap, which is a stitching together of the retinal nerve fiber layer and ganglion cell OCT scans. You can see the significant loss there. And then the 24-2C test pattern showing central field loss in the inferior arcuate region for this patient with what used to be ocular hypertension and now obviously is moderate stage glaucoma. Another example of a glaucoma suspect with stereo disc photographs. Again, just sort of the baseline for, you know, I'm in a teaching academic institution here, teaching my residents and students that, you know, despite OCT and how great it is, and despite the wonders of visual field testing and everything else, looking at the optic disc is still what our bread and butter is. And doing it with photography is a really great for the practitioner and really great documentation for the patient. This patient shows some nerve fiber layer loss inferiorly in the right eye, as you can see on the PanoMap report there, and maybe just the earliest of signs that are starting to show up on the visual field with a couple points in the nasal region and then a point just paracentrally, superiorly, and maybe that's an artifact point inferiorly. I would like to follow this patient up with a 24-2C pattern in the future. And my last example here is of a 48-year-old with pressures of 35. Again, wide field photos. the ability to zoom in on those photos and look very carefully at the optic disc, neuroretinal rim, retinal nerve fiber layer, disc margin, look for disc hemorrhages, peripapillary atrophy, the things that you can't see on OCT. And then, of course, follow it up with a CETA FASTER 24-2C test pattern, as well as your PanoMap reports from the Cirrus OCT. So again, my gist here and main points I wanted to make was using wide field and ultra wide field imaging to increase our efficiency in documenting the optic nerve in glaucoma patients, identifying those things that sometimes are not seen on OCTs, and also having good baseline images for moving forward. Visual field testing remains essential. Shalini, you're going to show us more of that. And also I showed you some examples of the OCT, retinal nerve fiber layer and ganglion cell layer change.
Okay. So with this patient, obviously I did a visual field, and the right eye basically has some non-specific changes. The left eye has non-specific central defects. So this year I followed up instead of the CETA standard with a CETA FASTER 24-2. And we can see here that with the CETA FASTER, as I explained earlier, it focuses also on some central points that you can get a greater information about the visual field defects in that area. Then in this case, we have basically, again, non-specific changes in both eyes, but I can feel more reassured that this patient can be continued to be followed as a glaucoma suspect and does not require any intervention at this time.
That's a great example, Shalini. Thanks. That's 24-2C giving greater confirmation. I agree. Thanks.
So in the second case, I have a 47-year-old Asian male who's being followed for low tension glaucoma. You can see in the right eye greater than the left. He also has a history of high myopia. Highest pressure is no greater than 19 in both eyes. Thinner corneas. His cup to disc ratio, you can see in the right eye about 0.775 with peripapillary atrophy, inferior sloping. And similarly in the left eye, slightly smaller, a cup to disc ratio with peripapillary atrophy, and a typical disc that you would see with myopic in a myopic patient. So I followed up with the visual field testing, and specifically in this right eye, he had significant visual field defects, superior nasal step, split fixation superior arcuate. And because he was not tolerant of any medications or sufficiently responded to any of the medications, I went ahead with angle surgery, GAT procedure in that right eye. Unfortunately, he did not respond to the surgery, had elevated pressures, ischemia of the iris, and then this required an emergent procedure where I performed a phaco with a toric IOL. Pupiloplasty was done with one of my cornea colleagues, and then a Barvelt for the elevated pressure. So you can imagine that this patient's already been through a lot in the right eye, and now we've been following the left eye as well, obviously. You can see in the OCT, so the right eye has the superior and inferior thinning, inferior greater thinning, as corresponds to the visual field defects that we saw previously. And in the left eye, you can see over the progression analysis from 2016 to now 2020, he's developing more of this wedge inferior defect. And this also is seen on the ganglion cell analysis in the left eye there inferiorly. You can see some thinning. And again, the right eye, the diffuse thinning. So it's very critical that I'm following his visual fields closely because, one, he's very young and he's already had significant visual defects develop in the right eye. So this left eye, we've been following with the CETA standard, and you can see in April of 2019, he's got some superior close to central defects, not the most reliable test with the higher fixation losses. And the testing is taking about 5 minutes, a little over 5 minutes. And then again, it's followed up a few months later. Similarly, not the most reliable test. And But so this year I decided to go ahead with the CETA Faster 24-2C, and you can see those central points that do confirm that there is potentially a shallow defect there. But again, this is a test now because it's only taking about 2.5 minutes in comparison to the 5 minutes that I've previously been subjecting this patient to. I can feel very comfortable in having him coming back, especially during this COVID time, to do more frequent follow-up testing. So we can both feel comfortable and confident that if there is a confirmed defect, then we should go ahead and do surgery. And if there's not, then we can comfortably follow him because he's stable, and that central critical area is being monitored closely. So shorter testing time, more reliable test, and greater central points are kind of the key with this 24-2C. So on our next case here, I have a 87-year-old white female, history of thyroid eye disease. She had decompression done 2011 in both eyes. She underwent cataract surgery. She developed residual angle closure glaucoma in the right eye, very elevated pressures, and she's currently on maximal medical therapy. You can see that OCT is consistent with the very significant thinning in the right eye. And then in her left eye, she has superior and temporal thinning. On the next slide here, you can see that she's got enlarged cup to disc in that right eye, some pallor, and her vision is consistent with that 2100 vision. And her left eye, her good eye, she's 20/25 and a moderate cup to disc ratio over there. You can imagine that this woman lives on her own. She's independent. She's relying on this one eye, and she's 87 years old. And I think, as Michael had mentioned, we've got patients who are living well into their 90s. So she needs good functional vision for, potentially another decade. When we're doing the visual fields, it's critical that I want to make sure that the central vision is stable and maintained. So you can see that this is, from the glaucoma workplace. The nice thing about the glaucoma workplace is that I think even for patient discussions, Michael, I don't know if you've been kind of pulling that up when you're talking to your patients when they come into the exam room. I think it's been really helpful in the discussions compared to what I previously was doing, but I can really very easily pull that up, show them over the last 5, 6, however many years I've been seeing them, that this is what your visual field has looked at like in the, in this eye, and how the progression has been, and they can easily see that, the dark areas are their visual field defects. So you can see that I've done CETA standard in this left eye, her good eye, and she's got an inferior arc, inferior nasal step, and the previous test that we did, now she's 87 years old, and it was in 2019. She had some excessive high false positives. And then now I just did this past month the CETA Faster and the 24-2C, and you can see that the inferior arc is present with the nasal defects, but the central area has been maintained and remained stable. So we can feel confident, again, just monitoring her. And even though she's on maximal medical therapy, we don't need to have a discussion at this moment about having to do surgery. Michael, what are your thoughts on the discussion part and educating patients?
I think it's so important to have large monitors in the exam room so you can show these things to patients, because we can talk all day long till we're blue in the face, and the classical picture's worth 1,000 words. And whether it's the trend line analysis and a negative slope for the VFI, or the grayscale getting worse, and you can apply the same principle to the OCT GPA analysis and everything else. So, we need large monitors to analyze our data, and we need them to show to our patients, and it just saves a lot of time. I usually have my residents and students get that up on the monitor in the exam lane, so when I go in to speak to the patient, it's ready for me to show to the patients.
Yeah, no, I think that's a great point. You were saying about the slope on the visual field index, and you can see here, this is this patient on the left eye, and it can kind of give you a prediction based on their rate of progression, where they may be in 5 years. So again, the rate of progression here is less than 1 to 3%, plus minus, and you can say that she should be able to maintain good functional vision for her lifetime if things stay the way that they're going right now. So again, another education. I mean, definitely with our glaucoma patients, it is all about education because they can't feel the pain. They don't know what's, exactly. They can't appreciate why they're taking these drops unless if you can show them in a tangible way.
Right. And with the increase of diagnostic testing, increased frequency of visual fields, as you said, if you don't show the patients the results, then I sometimes wonder, they don't know what I'm doing with that data. They don't know why I haven't come into the room for 5 minutes because I've been analyzing it in another room or whatever, whatever your workflow is. So being able to show the patients these results is just really great patient education, as well as in my environment, academic information for my students and residents.
Well, that was great. That was an outstanding introduction to both the new software with the Humphrey Perimeter and the value of fundus photography. And then, of course, you tied in some OCT. A lot of questions come up, and we have a few minutes to answer some of the questions from both the attendees as well as from each other. While we're waiting for those to be listed, I'm just curious, for some of the advanced glaucoma where you perhaps can't use a CETAFAST and maybe you've got a central island. Could either of you talk about how you approach the patient with more advanced glaucoma and what visual field program you'd use?
Yeah, I'm typically going to a 10-2. That's going to be my go-to for those patients. Be interesting to see on some of them, these were advanced patients too. So the 24-2C still was helpful if they're more of like a split fixation type of visual field loss. So that's, and as we know, the OCT, there's a floor effect. So you're really relying on your visual field and or on those disc photos that Michael was talking about. And I think that's also where there can be some value in looking at some subtle changes too.
Mm-hmm. Michael, any other thoughts on that?
Yeah, the 10-2 test, many with a size 3 stimulus, and I even have a few patients where I need to use a size 5 stimulus for really near end-stage disease. And I find, while the 10-2 test can be pretty tedious, if you're running it with the CETAFAST algorithm, there's not a faster for the 10-2. Most patients, if they're decent test takers, can get through it. And as you said, that's how we're ultimately sometimes deciding progression or not in these very advanced patients.
Yeah, well, certainly one of the big concerns in this COVID world is how do we disinfect the bowl? Yeah. And you can see on this slide here, these are the recommendations from Zeiss. This has actually been worked through with both the American Academy of Ophthalmology and a group of other, the American Glaucoma Society. And these are the current recommendations. This may evolve, but I think this is certainly what we're doing. Any thoughts on this? Anything different? It does take a few more minutes, but I think it gives patients a little more confidence that the disease will not be passed on.
Yeah, I mean, again, all of our patients are getting screened anyways before they come in, temperature check and the questions, they're wearing masks, we're taping. Like I was saying in the video, the ventilation part. I will say with the CETAFAST too, my technicians are saying because it's very intuitive with the setup, they're barely spending any time actually in the room kind of coaching the patients. So there's actually that kind of decrease in exposure to another individual, the social distancing part of it. So I think that's also very helpful, in addition to all these disinfection measures that have been, presented by Zeiss to do, which we're doing as well.
Good. So a couple of questions that have come up from the audience. One had to do with kind of a basic question about how you analyze visual field printouts. And we all have our own little style. I mean, obviously you could look at the grayscale and you could look at progression analysis. Quickly, what do you recommend?
Go ahead, Michael.
I would start, checking reliability indices, particularly false positives, gaze tracking, make sure that it's a good test and the right test. I spend most of my time on the total deviation and pattern deviation plots, and then the glaucoma hemifield analysis. If you want to simplify things, that's where I put my money on a single field analysis.
Yeah, and I think that's really important. The reliability issue is there's definitely a learning curve with taking a visual field test, and we know our patients will take a couple of tests before they kind of get the hang of it. The patients are aiming to impress us, to show how good they're seeing, and the tendency to kind of push the button more than they should is an indicator that they're not fully trained, and they have to learn that they're going to miss half of these. They're only going to see half of the questions, and it's important to get that point across to the patients when they first start taking it.
You have to train your technicians and perimetrists.
Definitely, this is absolutely critical. I mean, to get good results, you got to get good data as well in there. Any other thoughts in terms of some basic? One of the things that you did mention was progression analysis. I think that's an incredible tool. And patients can, again, you said, I think you both mentioned that patients can see that. How do you incorporate progression analysis with perhaps CETA Faster or 24-2C? Is that included in the progression analysis?
That is. So that's the nice thing also, is that, with the glaucoma workplace, basically it can be compared. So I'm not losing all that data that I've accumulated on these patients. I can actually, that's integrated into the progression analysis. So that's very helpful.
Good. Well, we're going to stop with the questions, and we're going to go to some recorded cases. So perhaps we can go ahead with that, and we'll come back to the questions from the audience.
Great.
Okay, those were great cases, and I'd like to share another one of my ocular hypertensive cases that was perhaps a little bit tricky, and also, though, using the same type of tools and technologies that we've been discussing thus far this evening with our equipment. This is a 36-year-old female. She has a history of high eye pressure and had, at another office, tried topical treatment for glaucoma and failed, and then lost to follow-up care. She has a history of poor follow-up, unfortunately, and also has a variety of other ocular problems that we'll get into a little bit. I think one of the other important things is that there's a negative family history of glaucoma in this woman, and there are not any significant medical history or systemic medications. Her initial visit to the Illinois Eye Institute was in 2017, and her chief complaint was ocular discomfort in both eyes. It had been lasting for several months. There was some dryness and aching in her eyes. By history, she had a sty or hordeola in the left eye. It was previously treated with warm compresses and an oral antibiotic. Again, the history of elevated eye pressure was noted in the history, and as I mentioned, she tried eye drops and then stopped them due to ocular discomfort. She's not taking any ocular medications nor any systemic medications. At this exam in 2017, a chalazion in the left upper lid was identified, blepharitis and meibomian gland dysfunction. Also noted to have anterior polar cataract in the left eye, and she had elevated intraocular pressures at 34 and 36 on Goldman tonometry. There was a small CD ratio and a healthy appearing optic nerve head. Education for all of these issues and appropriate follow-up appointments were made for the patient, and she returned in about a month for OCT imaging. And I'll show you that next with her serous RNFL and ganglion cell analysis there. That shows, pretty robust and healthy retinal nerve fiber layer for the right and left eye. Average RNFL thickness is around 94 microns and 89 microns for the left eye. No other flags on the RNFL quadrant plots or the clock hour plots. The RNFL thickness plots also appear to be relatively normal. A couple of scattered things that you might see on the deviation map. And then really nothing but a tiny bit of artifact perhaps on the ganglion cell for the left eye. So unfortunately, though, the patient did not return for any of other follow-up care, and she didn't return to our institute until 2 years later. And she presented into our urgent care service, again with the chalazion in the left eye, now more uncomfortable, and she wanted it removed. She really had sort of forgotten about the high eye pressure and all the education and information that we gave to her. She's had symptomatic dry eye and meibomian gland dysfunction on a more constant basis, and that seemed to be a problem for her. Her intraocular pressure remained elevated from her previous visit in the mid-30s, no other new findings, and she was referred for a glaucoma evaluation prior to referral for the Schlesy excision in her left lid. Here's just a snippet out of my electronic health record with her eye pressure and pachymetry findings. So you can see in 2017, she was 34 and 35. In 2019, she was 32 and 35. And then her pachymetry findings are 620 for the right eye and 634 for the left eye.
Michael, could I just ask her gonioscopy? Do we know if she was an open angle?
Yes, her gonioscopy was done at this glaucoma evaluation, not at the initial one, and her angles were open.
Okay.
Excellent question for somebody with elevated pressure, and you know, any glaucoma suspect should have gonioscopy done. Photos were done in 2019. This is on my previous Zeiss camera before I got the Claris, and they're basically just, you know, close-up disc photographs, but they show good, you know, healthy disc appearance, retinal nerve fiber layer, sharp disc margin, you know, small cupping in each eye. Nothing really significant there, I think. We took a picture of her congenital cataract in the left eye, just to document that and, you know, maybe consider how that might affect her OCT or visual field or her visual symptoms, things like that, which it really wasn't. These are her first visual fields. CETA faster, but the regular 24-2 pattern. You can see, you know, probably pretty typical first-time test taker results. Shalini, would you say?
I agree. And, you know, again, I always do find that there can be some drop-off, you know, when we go from the right eye to the left eye, just as one fatigues. And then, of course, the first thing that I always look at also is, you know, lid position on a patient, if there's any germaticulasis, ptosis, and, you know, potentially repeating the testing with the taped lid. And if you've done a CETA faster, well, you don't feel so bad bringing them back a little bit quicker to tape the lid and repeat that test.
Exactly. So one of the other tests that I use fairly regularly is corneal hysteresis. You know, it's sometimes a game changer, sometimes it's just additional information, sometimes it's confirmatory, sometimes it's a helpful predictor for what might happen in the future. High hysteresis values over 11.5 over 12 generally suggest a lower risk of developing glaucoma, and that's what the ocular response analyzer found here for this patient. There's a number of other IOP measurements that this will obtain for you in addition to the corneal hysteresis finding. That's the primary data point that I use for the Aura instrument, but you also get a IOP-CC, which is the corneal compensated IOP, supposed to be a more accurate, more true reading, taking into compensation the corneal biomechanical factors that are integrated into the hysteresis property, which is sort of, you know, that elasticity ability of the cornea and therefore the lamina curvosa to deal with elevated intraocular pressure. So it's a supportive finding along with the thick pachymetry to suggest that maybe this patient is at low risk for glaucoma. That's why I included it here. But for discussion points, so a 35-year-old, pressures in the mid-30s, you know, a couple other things going on ocularly. What would some recommendations be in terms of, you know, treatment plan? And
Sure. I would think, you know, one of the first things that I would consider in this non-compliant patient, I mean, thankfully, we're still dealing with, at least based on that OCT, pretty healthy optic nerves. So, and I mentioned the gonioscopy part, you know, the first thing that I would consider would be SLT, selective laser trabeculoplasty, in this patient, and see if we could get a response, you know, especially with the LIGHT trial that just came out last year, supporting, you know, the use of the of laser as even a first-line treatment that many of us were doing, but even giving more credence to that. You know, this might be a great patient, a great candidate for first-line treatment.
I think that's a great consideration, and I have that point on a slide coming up. I wonder, in a 35, 36-year-old, is SLT always the most effective way to go? And sometimes I find that, SLT is not as effective or as long lasting in those younger patients, but
That's a fair point. Still, I do find that, again, where is our target pressure? Depending on if we get her even to mid 20s. I believe the corneal thickness was in the 600s.
yeah, so
So
like 630 almost.
yeah. So I mean, we don't necessarily need to get pressures that are in the teens. It
Yep.
could be mid 20s, and that's sufficiently low. And we're moving to an era where there's intracameral medication injections. So as we make progress in that arena, there might be an opportunity to at least do a laser for now, and as things improve, in that might be options in the future for some of our non-compliant patients. I mean, I do find that glaucoma, sometimes it's all about buying time. So if we can buy time until the next innovation.
You're exactly right. To just do a quick summary of the next few months of this patient from last year moving into this year. We did first start back with a trial of latanoprost. That's what the patient wanted to try first. There was a decent initial response into the with IOP in the mid-20s, but again, she had tolerability issues. Now, probably that's because I overlooked the things that I preached everyone else not to do, which was overlook the treatment of her dry eye symptoms. And probably needed to tackle both problems at the same time, or at least get my cornea colleagues and my dry eye colleagues involved in that. So anyway, she ended up discontinuing the prostaglandin analog. We did the dry eye evaluation. That sort of went back and forth for a couple months. 6 months later, she comes back in, and I wanted to repeat the visual field test again with the 24-2C and the CETA faster algorithm. I felt more comfortable repeating it more quickly in what I think is, at this time, what was thinking still sort of a high-risk patient with pressures in the mid-30s and low 30s. And I think the results for the right eye and left eye here are still, we're settling out her test performance. Maybe there's some early stuff in the left eye, maybe not. But we need to build that baseline of 2 tests and then look for any change over time with the progression analysis. And I also repeated the OCT in 6 months, which is something I don't typically do. I mean, if you have a good OCT, but sometimes I just, I'm not confident I got a good result, or, even with a high signal strength or
I think I found, even sometimes I've had some patients with acute angle closure, and you do that OCT, it might be normal, but then 6 months later, a year later, all of a sudden you see that drop off. So I agree with you that there was some value in doing that, especially because she's had this consistently higher pressure. Sometimes it takes time for the test to catch up with the damage that's already occurred. So I think that was an appropriate thought to have in repeating my OCT.
Great, thanks. Right, not typical in all patients, but in those, strange patients. So, we talked about other medications. We did talk about SLT. Her IOP fluctuation remained from the mid-20s when she was able to tolerate. We tried bromonidine for a bit. We even tried timolol. Right now, she's on no medications, and her pressure's still at 31.
Okay.
Let me show you the most recent. This is from earlier this year in 2020. Her wide field Claris photos, her close-up Claris photos, and even closer up Claris photos. Visual field test number 3 coming up. Went back to just the 24-2 pattern, and she had a bad test day, I think.
Yeah.
When you put it up on the progression analysis, it just doesn't sort of make sense with everything else.
Right.
OCT, this is her 3rd OCT now. The first one was in 2017, and then 2019, and then again in 2020.
Yeah.
Is something starting there inferiorly in the right eye in the ganglion cell region? Maybe. Here is, and we can do her GPA analysis for the right and left eye on the RNFL. And it's actually, if you go by average RNFL thickness, pretty steady.
Yeah, especially since you've got, your baseline from 2017.
Yep. And then we have her ganglion cell GCIPL GPA.
So, I mean, I think there are patients that sometimes are just ocular hypertensive and then don't convert. And you're doing all the right things, which is just continuing to follow, monitor, and collect the data. And you know, if she does develop a change, then you're going to intervene. But it is a thought to potentially, you know, offer SLT. I do think that, you know, now that we can offer the light study data, patients seem to, when I tell them, you know, when they looked at outcomes and then patient satisfaction at both the laser versus the drops, is pretty much the same. And you know, I tell patients that it's done on a routine basis, and you know, no patch, no shield afterwards. So I think it seems to, it's all about how we present it. And I think
Yes.
when patients hear laser procedure on my eye
Yep.
versus, oh, I can do an eye drop, you know, more often than not, they're going to say, I'll do the eye drop. But if we present it in a way that this is a procedure that I do routinely, that most patients tolerate it without any issues, and I feel very confident about the results, and we have data to back this up, then I think they may be open to it. And I think sometimes the younger patients might be more open to it as well.
Yeah.
So it's
Especially
something
this woman that had such difficulty with topical medications.
correct,
You know,
correct.
and
correct.
even though we're working on her dry eye and everything, you know, that's a real difficulty. And you know, you referenced the Duresta, the bimatoprost
The Metapress, yes, system
implant.
released. Yep.
Yeah, and so that might be, you know, something we consider on her in the next 6 months or so as we get more involved with that.
I think that would definitely be a good consideration in a non-compliant patient like this, or one that is not able to tolerate the medication. So,
Yep.
Yep, there's a lot of great options for her in the future.
Great. Thanks for your input there. That helps a lot.
Okay, so thank you, Michael, for sharing that interesting case management case that you had. And I thought we were going to end today with a couple cases of, you know, kind of outside the box of our typical glaucoma patients, just thinking of other reasons to be for treating and how we manage those patients. So not infrequently get referrals and for abnormal testing. And in this case, this patient, a 70-year-old white female who's referred for glaucoma evaluation with an abnormal OCT and borderline pressure in the low 20s, history of hypertension, hypothyroidism, arthritis. She hasn't had any history of surgery, laser, or trauma. She does have a family history of glaucoma, you know, in her grandmother. So you can see that it's red on the OCT, on the deviation map, and you can get the impression that there might be, you know, diffuse thinning in both eyes here. And we did, you know, a visual field test. Unfortunately, that looks like there's significant general depression and an inferior nasal step, as well as an inferior arcuate in that right eye. And then the left eye, see some circumferential defects. These are her optic nerves. You see kind of like a small crowded disc, but very concerned about the OCT and these visual field defects. Her pressures consistent with what they were before, low 20s. Thankfully, her vision is 20/20 in both eyes with some mild cataract changes. So, Michael, do you tend to get some, you know, referrals with these abnormal red disease kind of patients?
A lot.
Yeah.
You know, because people always believe what the OCT tells them, and that's just not the case.
Right.
And it's a perfect example of having to have a good view in the back of the eye, a great photograph, and know that everything is not glaucoma in the back of the eye.
Right. And red does not mean that this is glaucoma and we've got to treat.
Yep.
So I'd like to go back, if we can, to the previous OCT. So if you can see that actually, if we look at the tomogram, you can see there's kind of this irregularity. It's not the typical concavity that you see with the optic nerve, and
looks bumpy.
Looks bumpy, exactly. The perfect technical term for that, bumpy. So if we go forward, basically, when we looked at the optic nerve, that crowded disc, it was more suggestive of potentially buried drusen. So, we ordered a B scan, and you can appreciate that lighting up the drusen where the optic nerve insertion is, consistent with the Barry Drusen, and I did end up repeating the OCT outside. That's the other thing to do. Whenever we get a referral, it's always important that you repeat the testing, so you don't know the quality of the testing, and just to get another baseline, as Michael had suggested previously when he's been doing his OCTs, even to see, is this really there's change, or are things stable? So in this repeat one, you can see that there's a little bit more normal looking optic nerve in the left eye, not all that red thinning that we saw in the initial OCT. And then we did a follow-up visual field, and in this case I was able to do the CETA faster, which in patient with optic nerve head drusen, we do want to really look at those central points as well to see if there's changes. And you can see that the right eye does have those inferior nasal defect, inferior arcuate changes, and then the left eye has some inferior non-specific changes. But even though this patient has optic nerve head drusen, does not preclude them from getting glaucoma. So we still need to follow these visual fields and see if there are changes over time, because they could have concomitant disease processes going on. So again, this is the CETA faster, gives us those central points as well. And just to always think, red does not always mean glaucoma. Think about other things that could be causing, especially when you're looking at those nerves and thinking, gosh, those are not cupped out optic nerves. That doesn't make sense.
Right.
And go back and look and see why you might be having red disease, but not necessarily the same clinical picture to go along with it. Michael, do you have any other thoughts on that?
These are, like you said, these are tricky and sometimes difficult patients, and the key take-home messages is get all the data. Sometimes don't act too quickly. Reconfirm the data, and make sure you consider other possibilities besides glaucoma. Great case.
Right. Yep. I agree with you. Reconfirming, repeat testing is always key too. Okay, we have a second case here. This is a 78-year-old African-American female who's being followed for glaucoma in the right eye greater than the left. She has a history of high pressure in the right eye, 37, thinner corneas, and an enlarged nerve in the right eye, about 0.9. The left eye, thankfully, has been pretty healthy. She's undergone cataract surgery in both eyes and trabeculectomy surgery in the right eye due to that advanced glaucoma. And these are her optic nerves and the fundus photography. And you can see that because of the peripapillary atrophy, this is going to affect some of the imaging testing. And the right eye is consistent with how I described it, with pallor, 0.9 cupped disc, and then a more moderate, healthier looking nerve in the left eye. So did OCT testing on her. And in this kind of patient with that significant peripapillary atrophy, you might not get the best image. So in this case, OCT might not be my go-to image to follow her. Do you find that too, Michael, sometimes that there's some of your patients that you're just maybe relying more on visual fields or
especially
photography?
at the end stage of disease or other patients with high myopia, the OCT just doesn't give you what you need to find and need to follow. So it is definitely visual fields when you can get it.
Yeah, and going back to, your fundus photography that you were discussing at the beginning of our discussion, These are the patients that, okay, you did the fundus photography several years ago, and now let's take a look and see if there's really been change or not. And OCT is not going to be the answer. So another, support for that. So I went ahead and, did her annual visual field test. And this was in 2019, severe depression in that right eye, probably at this point should be converted to a 10-2 in that right eye. And then the left eye showed an enlarged blind spot. And this year we went ahead and she came in to do her visual field testing. And I did the CETA faster. All of a sudden now we see a significant decline in that left eye. And again, this patient's monocular. She's relying on that right eye. So this is very concerning as to what is going on. So Michael, the first thing you would probably do is repeat this.
repeat this and go back and look at the patient and make sure that I have a reason for why that change came up so quickly in the patient. So consider other possibilities.
Yep, absolutely. And that's the perfect answer. So, repeating would be one. Oftentimes if patients have dry eyes, that could be an issue. I mean, that's like the most common reason. So the first thing I kind of look at is, like you said, looking back at the slit lamp, the clinical exam, the cornea, is it clear? Did the patient have significant punctate epitheliopathy? Do they just need to have, a month of artificial tears come back and we repeat the visual field? And not infrequent where I see a sudden improvement. This patient was pseudophakic, so it's not a cataract, but I did notice that she had developed a significant secondary cataract. And, the rest of her clinical exam, when I looked at her optic nerve, it looked pretty healthy still. So when I instead of having her come back to repeat the visual field, I decided, let me go ahead and do the YAG capsulotomy. And then thereafter, I went ahead and did the repeat visual field, and look at that, success.
We do that in glaucoma all the time, right?
I know. Wouldn't that be
The visual
wonderful?
field better.
Yes. So she's happy. Clearly much happier. And again, the key is repeat testing, look back at your clinical exam, and go from there. So.
Great.
Well, those are great examples of glaucoma. And if there's something we can say is, we used to struggle to get good reliable data. Now we've got lots and lots of data. How do you differentiate? One of the questions that came up from the audience was, why do you need a camera when you've got good OCT data? And you could do the reverse. And why do you need an OCT if you've got optic nerve? And I think you mentioned a few things. There's lots of times where one works and one doesn't. But perhaps is there any simple answers to that question? I think they're both really valuable and they both provide good insight. What are your thoughts?
I pointed out a couple of examples of things that you don't see on OCTs, such as, disc hemorrhages and peripapillary atrophy. Of course, you'll see that on clinical examination, which we still continue to need to do on patients. But also it's documentation for the long term for these patients. Our OCT devices will continue to improve and change in technology and format, and hopefully they're backwardly compatible with our existing data, but maybe not. And over my 30-year career almost, I've been saved many times by going back to an old photograph and making a decision for the patient that I wouldn't have had otherwise just with OCT.
Yeah.
I think that's a great point, Michael. I mean, especially when patients right now are so mobile, they'll be one place and then 10 years, they might be somewhere else. So if they have those photos to take with them, that's much more valuable than probably the OCT, like you said, changing from the Stratus and the time domain.
And I think, a lot of times that you can show some pictures to patients, or you can show them the OCT, you can show them progression, and that emphasizes the need to be compliant and adherent to the recommendations. So a lot of times people just don't, of course, the only time they take their medications is when they come to see you. And that's probably our biggest problem. So, using this data judiciously, wisely is very important. Now, on the other hand, one of the things that you just pointed out was the artifacts that show up. You showed it in some ways with the Drusen patient, and you showed it with the patient who had, pacified posterior capsule. We really have to be on guard. How do you walk through that? How do you get through that in a clinic then?
Yeah, I know that's, I think that's key. Like you were talking about the visual field, like evaluating, somebody had a question about that. I mean, I think the key is you look at all of the data, the reliability, but you always have to kind of, glaucoma is putting a puzzle together, right? So just really, those were a couple cases where it's not making sense, it's not correlating, and you just have to take a minute to really go back and do the basic. Let's just look back at the slit lamp. How often do you see a visual field that there's a drop off and it's dry eye, right? I mean, all of a sudden you're thinking, do I need to do surgery? This patient looks awful. And then you go back and you're like, oh no, it's just dry eye. We can fix that and hopefully make an improvement. So I know we live in a time right now where it's like, we're going so quickly. We've got, like you said, all this data and we're trying to integrate it all, but sometimes it's just getting back to the basics.
Yeah.
Rick, I tell my students and residents, just because it's glaucoma clinic, that doesn't mean that's the only disease the patient has.
Very good
So
point.
all of us, we have to be the best diagnosticians possible, and we always have to be on the alert for the masqueraders that we saw tonight and everything else. And just because, it's red on the OCT, we use that term red disease, that
Right.
doesn't mean it's glaucoma.
Yeah, yeah. Well, one of my good friends in Sydney, Australia, is asking a question about the use of the ocular hypertensive study risk calculator and using that with our patients. Of course, that
I think
came
that's
out
great.
in the early 2000s. It played a big role at that time. Are you still using it now, and how to use it?
I still use it. I mean, definitely like the patient that Michael have, like you were saying, it's all about, kind of feedback for the patient's education. And so I think for them, if I can say, listen, we have this study, this calculator, let's put in the point system, let's see what your risk is based on 5 years. And, if I say it's 15%, well, then they're more likely to, then I would suggest that we go ahead and treat. It's less than 5%. Well, we can watch and we can recheck this calculator next year. I think it's very helpful in the education standpoint.
Right,
I
right.
agree completely. I think it's a great tool for a lot of practitioners. We should all know it's not perfect, of course. No risk calculator is. It doesn't include family history. It doesn't include the presence of a disc hemorrhage in the patient. Doesn't include ocular perfusion pressures and other risk factors that we know are present in glaucoma. But it doesn't mean that it's useless. And it's been validated, as you know, in a couple of publications.
Right, right. Now, are you both using Forum to incorporate all of the Zeiss data? I find it to be tremendously useful.
Yes.
Yes.
I
Yes.
mean, I think as far as time saving is great,
Right.
and the education part. Before I was using the Zeiss Forum and I was having to click through and put it on a grid, and gosh, you're just, again, all that time that you're taking yourself to interpret. But if I can save that time and bring up the browser, and all of a sudden they can see, this is your right eye over the last 5 years, this is your left eye, it looks stable, or I can see it's progressing. Now we've got to really think about, are we going to have to do surgery? We can show the progression analysis. It's been a great time saver and
Yeah.
education tool.
I have to say it's essential almost. I mean,
Mhm.
as you pointed out, Rick, we have a lot of data. It's how you manage it. It's how you analyze it. Data is king and all those other sayings that go around. And that's where we are, I think, in glaucoma care and, many other subspecialty areas. So it's really important to manage it. And practices, have shifted a little bit. I think I can spend better quality time with the patient if I do this review in a separate room or whatever your workflow is. And we talked about using the educational tools with monitors and things to the patients.
Right. So we're going to have a talk in a minute here from Gary Lee, who's one of the heads of research at Zeiss. In your own wish list, if you could, wish for something to better diagnose and treat glaucoma, what would you each like to see?
Oh, at home visual field testing.
Yeah, that's a good
At
point.
home
Yeah,
tonometry, especially in
Yeah.
this age or in this
that's a
time. We're
great
just
idea.
like, gosh, if we could have both of those,
Yes.
we would be able to see our patients virtually, or at least,
Yes.
yeah,
Yeah, yeah, that's a
that would
good
be
point.
huge. Yeah.
Michael, any thoughts?
No, those are two top on my list, I guess.
Right.
Yeah, no, those are great. Well, let's turn our attention to what Gary Lee from Zeiss, and we look forward. Zeiss is our technological leader, and we've also been so dependent on the equipment, and we look forward to what the next innovation is going to be. Maybe Gary could share that with us.
Sounds great.
Thank you, Dr. Lewis. Hello. Thanks for the introduction. My name is Gary Lee, and I'm a scientist in Zeiss's Research and Development Group. My team works in algorithms and applications development in the area of visual fields and OCT glaucoma applications. So today I would like to discuss two topics relating to the next generation of perimetry strategies. The first topic today deals with size 5 visual fields. So I would actually like to start with the conclusion, and that is larger parametric stimuli will likely be used in the next generation of testing for white-on-white standard automated perimetry, or SAP. While we know other forms of perimetry, such as FDT screening or kinetic testing, have traditionally used larger size stimuli, clinical gold standard visual fields for standard automated perimetry are typically performed with Goldman size 3 stimuli. However, larger stimulus sizes in SAP may actually provide a viable alternative to size 3 for the reasons I would like to discuss today. We know very well that increased variability in visual fields can be due to scotomas. In addition, as glaucomatous damage progresses, current testing strategies may run out of dynamic range, making long-term monitoring difficult. Furthermore, in many cases, such as in late-stage disease, a switch is often made to a different test, such as perhaps full threshold size 5 or 10-2 visual fields, which may result in a loss of longitudinal patient history using the same visual field test strategy. So one aspirational goal is to develop one test that can be performed from early to late stage disease using today's modern test strategies, such as CETA on the HFA. So what advantages do larger stimuli offer over size 3 stimuli in SAP? Key advantages are larger stimuli are known to produce better test-retest variability and have larger effective dynamic ranges, even after accounting for the total energy of light reaching the eye. Also, from a more practical perspective, larger stimuli are more resistant to optical blur and may in fact make the visual field test experience easier for subjects. So a practical question is, can larger stimuli actually detect glaucomatous defects? So many clinical studies have, of course, been performed to answer that question. For example, Wall et al. Showed that size 5 performed as well or better than size 3 and 6 in detecting scotomas in a wide range of glaucomatous eyes. Note, this study also included a custom test that focused on changing stimulus sizes as well, rather than stimulus intensities. However, we know from theoretical ganglion cell receptor field sizes and spatial summation that based on eccentricity and scotoma depth, smaller stimuli might be preferred in some cases, especially in early glaucoma and in the central visual field. So we also conducted a study to investigate the question, can larger stimuli effectively detect glaucomatous defects in early glaucoma? Thus, Flanagan et al. Performed a 3-site clinical study, as described previously, in which 96 early glaucoma eyes with MD better than -4 dB performed the 24-2 full threshold visual fields for sizes 3, 5, and 6 at 2 separate visits within 3 months, as well as a qualifying 24-2 CETA standard visual field. 118 healthy age-bin eyes were also collected to serve as a reference database for flagging glaucomatous defects at the 5% level. We found that size 5 stimuli flags glaucomatous defects as well as size 3 stimuli in early glaucoma, including in the central 10-degree visual field test locations. We also found that test-retest variability improved to size 5 while maintaining comparable specificity. In addition, we also found that both size 5 and 3, of course, again, also outperformed size 6. So in conclusion, the increased dynamic range and improved test-retest variability that may be provided by larger stimuli may support testing strategies that may be used from early to late stage disease. And as such, larger size stimuli will likely be used in the next generation of SAP testing. Next, I'd like to discuss the use of structural imaging data to speed up visual field testing. One way that modern thresholding strategies, such as CETA, have improved test times is by using prior information based on population or reference database results. And it is also well known, especially in glaucoma, that structure and functionality are typically very highly correlated. Therefore, we wanted to explore the possibility of leveraging the structure-function relationship plus AI techniques to accelerate visual field exams. In this proof of concept study, we evaluated the performance of using visual field priors derived from structural information, what we call S priors, in simulated visual fields. The data we used in this study was retrospectively taken from a Singapore population study containing about 1,400 eyes of 1,400 subjects. 24-2 visual fields and 200 by 200 optic cube scans were acquired from HFA and Cirrus, respectively. So we split the data 70 to 30% for training and testing purposes. The training data was used to train 2 types of AI models, artificial intelligence models, to predict the visual field S priors from the OCT data. First, a classic random forest regressor was trained using Arnefelt thickness Tisnet profiles and subject ages as inputs. That is, we took the TISNet profile and created these S prior visual fields as shown on the screen. Second, a simplified mixed-scale dense convolutional neural network, or CNN, a modern form of artificial intelligence, was trained using 2D RNFL thickness maps as inputs. That is, we took the 2D thickness maps for RNFL and created these S prior visual fields. Then in the next step, the reserved test data was used A, to generate AI predicted S priors for use as individualized priors, and B, to provide true visual fields to a visual field simulator. And what does this mean? Typically, when I take a visual field with a test comparable to CETA, which uses pre-existing population reference data to accelerate the test, I'll sit in front of the perimeter and respond to the CETA testing strategy. In simulation, however, the actual 24-2 visual field that we collected earlier, the true visual field, serves as the patient. The probability of response at each test location was modeled using frequency of seeing curves, which we did in this study as previously described by Henson et al. We also set false answer rates to 0%, 5%, and 20% to represent 3 styles of responders. So really reliable responders or not so reliable responders. And then for the simulations, we then implemented a Bayesian ZEST strategy, which is a simple surrogate for modern strategies such as CETA, which also uses reference population data. Then we implemented modified ZEST strategies using our S priors instead of population reference data, which we call here ZEST-RF and ZEST-CNN in the remaining slides. So for the data analyses, the performance between the final simulated and input true visual fields was evaluated by looking at the mean absolute error, or MAE, for accuracy and the total number of stimulus questions for test duration. Equivalence tests at a confidence level of 95% were also performed to evaluate inter-strategy equivalence for both ZEST-RF and ZEST-CNN versus ZEST. And then the limits of equivalence used were 0.5 dB for MAE and 5% for total number of questions. And this is what we observed. We observed that the AI models perform better in the higher threshold sensitivity values versus the lower thresholds. As you can see, this is likely due to the fact that less than 4% of the training data thresholds are below 20 dB in the population study data, i.e. this is a pretty severe training data imbalance. Nonetheless, for the majority of the fields in the study data in which the thresholds are greater than 20 dB, the predicted S prior visual fields, as you can see, achieved lower MAE values in these 2 examples. However, as you also might expect, fields with deeper scotomas, such as perhaps arcuate defects, resulted in larger MAE values and S priors that are not accurate as they could be. And in terms of the simulations, the number of total questions was reduced 16 to 19% using S prior information. And overall, the accuracies for ZEST-RF and ZEST-CNN were equivalent to ZEST within plus or minus 0.5 dB. And also, as we might have expected, the accuracy decreased and the number of total questions increased, basically got worse, with increasing responder false answer rate. So more false positives and more false negatives. So in conclusion, overall, the preliminary findings suggest that in this population, even models with limited data used to predict structure-derived visual field priors, or S priors, from OCT data can reduce the duration of a visual field exam with pretty comparable accuracy. And we believe that with more data, better representing a clinical population, and with more refined AI models, we think the performance may be further improved. So with that, before I finish up today, I'd like to thank and acknowledge our many colleagues and collaborators, and thank you so much for your attention, and be available for any questions and discussion. Thank you.
Gary, thank you. That was great. A good touch on what we are all looking forward to in the future. You know, what we all want is reliable, reproducible visual fields, OCTs, pictures, fundus photos, something that's going to give us a prediction of how our patients doing now, as well as what they're going to do in the future. You know, what the biggest challenge we all have is not just preventing visual field loss, but trying to predict who's at high risk for it. You know, we'd love to have a neuroprotective drug, and you know, we've had challenges. The FDA has not accepted OCT data yet. They still depend on visual field studies validating that a drug is truly neuroprotective. Any thoughts from any of the panelists about how to approach this in the future? And I guess what I'm asking is, what we'd like is a predictive test, someone who's at higher risk than others, and also a test that can tell us if we have a treatment, whether it's surgical or medical, that can protect the nerve and provide that neuroprotection. Any thoughts there?
As far as the testing goes, Rick, one of the things I think about is, yeah, predictive is very good, but as we're dealing with, we mentioned earlier, older and older patients, we need some testing ergonomics that make sense for our patients. So I've seen some of the virtual reality, and, Shalini mentioned home testing. So that is important. And, if patients can do more testing, maybe that can be predictive, as you were asking us to, figure out which one of our patients need aggressive treatment and aggressive intervention versus those who are not going to end up with functional vision loss in their lifetime. And we can sort of treat them each a little bit differently. I know there was a question in the Q&A about how frequently do we see glaucoma patients? And one standard answer is every 3 months. And I don't think that makes sense for every single glaucoma patient that we all see. Some patients can clearly go longer than every 6 months, and we have to prioritize our resources and individualize the treatment options that we all have for our patients today.
Yeah.
Good points.
One of the other questions that came up towards the end from the audience had to do with functional ERG, or VEP, as a testing tool for glaucoma. It's been around a long time. A lot of question marks about it, a lot of questions about its reliability. Is anybody using that? Anybody see a future in either of those two tests for glaucoma?
I've never used it. I don't use it. I'm not sure the data is really there for us to use it clinically. I think in the research lab, there's certainly a long history of electrophysiology testing in glaucoma, but clinically, the data is not there in my opinion.
Yeah.
I think the access and the time it's the challenge, right? So we're relying on the other modalities right now.
It's a nice, it's a nice want to have a more objective test.
Yeah.
I think refinements in perimetry, and this was exciting stuff that Gary showed with a size 5 stimulus. I had heard about that years ago and wasn't really sure that there was further work going on with it. But if you can save 20% test time and have a reasonable prediction about where the field defect is, then again, it's maybe, two tests a year, which sounds horrible, but we're thinking old days for visual field testing. And it's all about that timeline, about rate of change. And so we all get concerned about those patients who are losing dBs at, 1 dB, 2 dBs per year. They are on a frightful course. So let's find that out as early as possible.
Gary, do you see that happening, that gets introduced into clinical medicine in terms of the size of the testing? Do you see that happening sooner or later? What's your thought there?
I definitely think it's going to happen in the near future. As you've been mentioning, that the goal is to find progression quickly and to quickly determine who's having reliable fields or not. And so not only do we need these faster tests like CETA Faster, we also want to leverage the larger stimulus sizes, whether it's 5 or 4.5 or 5.5, whatever happens to be, to extend the dynamic range like we're seeing. But the key part of the size 5 stimuli is that they're more repeatable, right? And so that means that when you have a test and then you have the larger dynamic ranges, you actually get more steps across that dynamic range. So you should, in theory, be able to see change more quickly. You should be able to see more change steps. So the kind of way I like to think about it is like, if you kind of think of the yellow, red, green in OCT, you can wait until the changes goes or it's dropped so low that now you're in the yellow or the red. And by then you've probably lost a lot of ganglion cells and it's too late. But by using these size 5, more repeatable tests and smaller effective dynamic steps across the range, then hopefully you're going to find maybe 2 or 3 or 4 more steps within the green, so you detect change when it's in the normal range before they've lost a lot of their ganglion cells.
Do you see a device? Do you see a device coming out in the future that incorporates all of this data, where OCT data, camera, fundus photo, visual field? Do you see OCT? Do you see that in some device that would incorporate a beyond Forum that actually does incorporate it, but then just spits out, that actually could give the clinician a different differential between reliability and reproducibility and accuracy for that particular patient. In other words, something that integrates it like what we're doing right now, but perhaps a machine does it for us.
I definitely think we're progressing in that direction. You know, I would almost say that I don't know how we would not go in that direction. It's kind of the next frontier, and it's just putting together all that information as quickly as possible and as most effectively as possible. And you know, at least from our perspective in the R&D teams, we're just trying to figure out how we can leverage algorithms or applications, especially now in this modern age of AI, how we can best do that to help you clinicians kind of pull that information together as quickly as possible. So yeah, to answer your question, I definitely think we're moving in that direction. So,
right. It's one thing to have, you know, AI and read a retinal photograph for optic nerve head changes or diabetic changes or whatever, but you know, why can't an OCT talk to a perimeter and be smart about it? And you know, to your point about size 5 versus size 3, why not tell the perimeter to show whatever is best for the patient, or a combination of size 5 and size 3? You know, it seems like it's not, well, I'm sure it's difficult, but whatever. That's my clinical side.
Well, it's definitely easiest if the machines can already talk to one another,
Yes.
right? So if you have an HFA, then you can definitely believe that it's very easy to talk to the Cirrus if, you know, right now everything goes one way into Forum, for instance. So you can very well imagine someday that from your Forum, you order some tests and then the data can move back and forth between the two. Perhaps someday in the future, the instruments will talk to one another, or you'll shoot into the cloud and it'll come back down to the other. So it's more of an infrastructure question. And it could also be in the future, there's more collaboration between instrument manufacturers like Zeiss and other companies to share this information. And as AI becomes more prevalent and democratized, then it will be easier to share information across you know, instruments and to be able to do these things you're talking about.
Well, we have hit upon the end of the hour, and I want to thank the panelists. Outstanding talks, great dialogue. Want to thank Zeiss for sponsoring this. Glaucoma still has a long way to go. I think we've made great progress. We still have a long way to go, and I think it's only through interactions like this that we'll actually move the field forward.
Thank you.
Good night.
Good night.
Thank you.